On May 17, 2026, the World Health Organization designated the Ebola outbreak in the Democratic Republic of the Congo and Uganda a public health emergency of international concern. The alert signals the absolute highest level of global health urgency. The virus moved rapidly through the DRC and quickly crossed international borders, confirming its first imported case in Uganda. Health officials traced the entire escalation back to a single presumed index case, whose symptoms began just 3 weeks earlier, on April 25th. By May 21, the DRC reported 746 suspected cases. The death toll had already reached 176 people in that country alone. Going from one isolated infection to an international emergency in under a month demonstrates that initial local containment measures were unable to keep pace with the virus's multiplication. The Democratic Republic of the Congo has managed 16 previous Ebola outbreaks, but the 17th wave is driven by the specific Bundibugyo strain. This image shows the physical biology of the virus. Unlike the more common Zaire species, there is currently no licensed vaccine and no specific cure for Bundibugyo. This medical vacuum means that healthcare workers and affected communities face an actively spreading pathogen without a dedicated pharmacological defense. The World Health Organization issued its highest warning level because we lack the pharmaceutical tools to halt its transmission. Once the Bundibugyo virus enters the body, it operates undetected. The infected person goes through a 2 to 21-day incubation period, symptom-free. The early phase brings high fever, fatigue, and muscle pain, mimicking diseases like malaria. The advanced phase brings vomiting, diarrhea, and rashes. Critically, the infection triggers systemic organ failure, causing extensive internal bleeding and external hemorrhaging from the nose and gums. The Bundibugyo strain uses biological camouflage. By presenting as a common flu during its early stages, it delays accurate diagnosis until the patient reaches an irreversible clinical threshold. The physiological stress of this progression is devastating across all age groups, but recent data shows that infants and adults over 65 rarely survive the infection. Paradoxically, the people trying to stop the virus face the highest exposure. Medical staff and family caregivers must make direct physical contact with patients, making them exceptionally vulnerable. Without a targeted antiviral treatment, clinics rely on optimized supportive care. Doctors carefully manage fluid and electrolyte balances to help the patient's own immune system fight off the infection. The effort to contain the fatalities in these wards relies entirely on the physical endurance of the medical personnel. The outbreak's epicenter spans the volatile eastern provinces of the DRC, Ituri, North Kivu, and South Kivu. The virus has breached dense urban infrastructure. Uganda has reported confirmed cases navigating the busy, highly populated streets of Kampala. Health ministries in 10 surrounding African countries, including Rwanda, Kenya, and Tanzania, remain on high alert. Despite the international emergency status, the broader global risk remains minimal. A recent scare involving a traveler in Bengaluru, India, resulted in a negative test, confirming the virus has not established a foothold in Asia or Europe. The active biological threat is localized to Central Africa. However, its entry into major transit hubs proves that geographic distance alone cannot prevent an isolated case from traveling. Ebola Bundibugyo has strict mechanical limits. It requires direct physical contact with the blood, sweat, saliva, or other bodily fluids of an infected person to spread. For anyone entering an active infection zone, full personal protective equipment is an absolute necessity. Prevention also requires avoiding the environmental reservoirs of the virus. Health officials warn against contact with primates and explicitly advise against interacting with fruit doubts or consuming bushmeat. The pathogen remains highly active even after a patient dies. Strict adherence to safe, sanitized burial practices is required to stop transmission during funerals. By avoiding the specific fluids and vectors that carry the virus, we can sever its path from one host to the next. Individuals outside the hot zones must practice rigorous hygiene. Continuous hand washing with soap and water or alcohol-based sanitizers destroys the lipid envelope surrounding the virus. Anyone returning from the affected regions in Central Africa must undergo a mandatory 21-day health monitoring period to clear the incubation window. On the ground, international authorities and agencies have mobilized to track cases and support local clinics. Simultaneously, global laboratories and researchers are running accelerated trials, working aggressively to develop and license a Bundibugyo-specific vaccine. Until those clinical trials produce a viable cure, our most effective medical intervention is strict adherence to safety protocols and informed public vigilance.